with 5 minutes for your questions.
Thank you very much, Mr. Chairman. Appreciate you being here this afternoon. The Medicaid Pharmacy Home Act that the committee is considering would require that states take into account a patient's history of receiving care in geographic proximity to providers and pharmacies when locking a patient into 2 providers and 2 pharmacies. How would CMS define proximity?
Well, that's a good question, and something that in each of our rulemaking we actually look to do. We recognize that we are always looking to make sure that we can ensure appropriate access for patients. As I said, we want to make sure people are getting the right treatment in the right setting, and so it's something that we are definitely always looking to determine what is the right proximity. Is it driving distance? Is it actual mileage distance? What is the appropriate balance? And that's something that we do through notice and comment rulemaking and working with individuals such as yourself.
And you anticipated the next part of my question, because I was going to go to historically, it's been a mileage requirement, but in districts like mine, which have mountains in them, you know, one town might be closer as the crow flies, but not nearly as close on driving time. So that, you know, I've got a classic situation in one of my areas where in Dickinson County, Hayside and Clintwood on the map may look like they're 15 miles apart, but there's a mountain in between. And because of the road that goes around the mountain, I have been advised by the mayor of Hayside that he allots, doesn't always take him that long, but he allots an hour to get from one town to the other. When he has a meeting over in Clintwood, he has to allocate an hour on his calendar. Weather, coal trucks, timber trucks, a slow driver worried about the curves, all can make that trip a lot longer. And there may be closer facilities that the drive time is better for, or whatever, and keeping that in mind. And just ask that as you all look at this, and we will too, if you would keep that in mind, I would greatly appreciate it.
We certainly will.
Thank you. In MACPAC's report this past June, the Commission noted research in Health Affairs that found states with prescription drug monitoring programs requirements saw a reduction in opioids prescribed to Medicaid enrollees, reducing the total scripts and the dosage as well, and a reduction in Medicaid spending on those prescriptions. A 2016 CMS bulletin also highlighted similar findings. Wouldn't you agree that this evidence demonstrates the critical role of the PDMPs in addressing the opioid epidemic, saving both lives and dollars?
Yes, we absolutely think the PDMPs play an important role. 49 states currently have a PDMP, and we are very much committed to continuing to work with them to ensure that they're as effective as possible. For instance, the state of New York, which has been requiring prescribers to access a PDMP, has seen a 75% drop since 2013 in the number of patients who use multiple prescribers and pharmacies for controlled prescription drugs just because of the PDMP.
And appreciate that. The Medicaid Partnership Act draft before us allows states flexibility in how they design their programs. However, it also ensures that PDMPs are a part of Medicaid's provider clinical flow work. If more physicians and pharmacists were checking the PDMP, would you expect the number of opioid prescriptions to decrease? I would.
Well, as stated with the example I just gave you from New York, we think that there is a lot of promise to having greater access to PDMPs and to making sure that people are utilizing them.
Now, here's an interesting twist that we have to try to figure out. If you have the prescribers checking it, is it duplicative to have the pharmacy checking it also?
Well, it's a good question, and as I mentioned before, we view the pharmacist as well as the prescriber as part of that care coordination team. So it's something where prescribers have been checking this, but we also view the pharmacist as a part of the discussion, and it's something we are certainly open to discussing with you all.
Yeah, and I think we do need to discuss it, because one of the things that it also says is that if there's a patient in hospice or palliative care, they would be exempt from the requirement to consult the PDMP. How's a pharmacist going to know that? The prescriber should know that, but
it would be, at this point in time, I do not believe that type of information would be available to people checking the PDMP, so that would be an impediment.
So we've got to figure that out if we're going to go forward on that particular line of the bill. But I do think we're all trying to work in the same direction, and I appreciate any input that you can give us to make our bill as we go forward and discuss it
we
better
look forward
and
to offering
practical.
Technical assistance, and this is an area that we've been very focused on, so thank you.
Thank you, and I yield back.